if that's everybody outside that's chimed in, I think we'll go ahead and start. These are our regular slides letting you know about Molina and our partnership with them, and roll call about how you might receive your CME or CEU. And again, my name is Carole Conley. I'm a social worker here at Envision, and I manage some of our primary care quality improvement projects. And also I've done a lot of training and schooling around motivational interviewing, but I won't go as far to say that I'm an expert, but I have some good ideas about how we can use this in our day-to-day practice. How I want to structure this is we want to frame it. Kirsten and I talk a lot about framing it as the spirit of MI, to take that pressure away from providers having to feel like they need to be experts and go through the MINT certification, and that there's one path that you go down to have a conversation with somebody in this motivational interviewing style. So we really talk about it as the spirit of MI, really trying to be person-centered in our approach and to be collaborative, thinking of it as an invitation that we are inviting people to really share with us what maybe barriers are to change, what they're excited about changing, how confident they feel about changing. And so it's very collaborative that way. It's evocative. I like that word. And what that means is we're really listening more than talking, and we're eliciting rather than advising. I really want to hear from you what your ideas are about making change. We put the responsibility for change on the patient, and they have control over their lives. And as much as we want to tell them, if you do this, you will feel better, there's no guarantee that they're going to do that thing you're asking them to do. So how can we build a partnership to work together to make the change? And that it's respectful, honoring their autonomy and their resourcefulness and their ability to choose. There are many people that aren't in the space to make the change that we feel like would be the most beneficial to them. So we're going to talk about motivational interviewing, the spirit of MI, in these first few slides, and then we'll really get to the assessing readiness and what that looks like, and understand that motivational interviewing takes practice. Practice, a lot of practice, and that you can practice in various places. You can practice at the grocery store with the checkout clerk, you can practice with your teenagers, your spouse, to change the way that you ask questions and elicit information from people. So really with MI, we're inviting people to consider making a change. There's a challenge, before I go on to the next one, in doing MI in a webinar kind of setting. I mean, I can give you framework and ideas and some sample questions, but it's really about having a dialogue, you know, and so maybe we can do some of that around the table with the people here. But just know that you could send me an email, give me a call, and ask me questions about any of the stuff in this, and we could talk further about it, and even you could come by and practice if you would like to do that. We like visitors here at Envision. So, okay. Why use MI? And I have references for this at the end. But what we found, and like this is an old one, this is from 2007, but there were 54 very focused, targeted studies around MI in 2007, and then 9 of them were the random control trials. And there was a lot of success. And that MI with active treatment, and by that, let's say we're talking about pediatric overweight, and we're thinking about stage 2, like our project with social workers in Roswell, that the MI style of communication, along with that active treatment in stage 2, can really have a positive effect. And we're going to list some of these studies on our website. We did not get to it today before the talk. I apologize, but we've been kind of running really, really fast around here. So the evidence is out there. I'll have the references put up on the website. And the thing I think about these research studies that we went through is that it reminds us that the power differential is reduced in the interaction. That with MI, a provider comes into the room really interested in hearing about the patient's experience, rather than coming in with that white lab coat and saying, if you do this, it'll all get better. Does that make sense? Mm-hmm. Okay. Stop at any time to ask me questions. MI supports self-efficacy, so when we start talking about the readiness or the confidence and ability to change, this style of communication already supports that self-efficacy, which could be equal to someone's confidence. Their belief in the possibility of change is an important motivator. Self-efficacy is really about saying, I can do it. I have some power to make this change. The patient, not the provider, is responsible for choosing and carrying out the change. And we found this, a lot of us, in our clinical practice, where the thing we want our patient to do is not the thing they're focused on. And with an MI style, we can figure out where that discrepancy is and maybe get ourselves on the same page. The provider's belief in the patient's ability to change becomes a self-fulfilling prophecy. I believe in you and your ability to do this, and it may not happen on the time frame I would like for you, but the possibility exists. You have that control. So when we're thinking about motivational interviewing and assessing readiness, we want to understand a little bit about stages of change. Now this is Prochaska and D. Clementi, I think I said that right, who really spent some time on the trans-theoretical model of change and what stages people go through as they're thinking about change. And I want to be clear that MI is not based on this, but this, looking at stages of change, gives us a place to see where our patients might be and the way we might intersect most effectively. They're listed up here. I have a cute little drawing about pre-contemplation. We're thinking, no, there's denial, I don't have a problem. This just kind of lists out what thought processes might or behaviors might be going on with individuals as they're thinking about it.
I like the last one.
Well, that's something to think about, because, you know, when we think about making change and we go along and we're doing really great for 3 months and then we have a setback, that's so common, but think of those setbacks as opportunities to learn something about yourself and your patient, you know? What pulled me back here and what could I do differently next time? Okay.
Such as, what are your barriers?
Yes, what got in the way? Thank you. Good way to frame it.
Or we just got tired.
Or, yes, and so that maybe we're not approaching the change in the best way because it's wearing us out and it's not making us feel excited because we have progress, so... The important stages when we're thinking about those stages of change for MI is the pre-contemplation. There's no interest in changing. There is an opportunity there for providers to maybe open the door a little bit and plant some seeds about the change. Then when there's contemplation, they're thinking about it, but they're ambivalent. They can't commit 100%. There's an opportunity to intersect with your patient. And then when we're in the preparation or determination stage, that's the action. I am committed to changing. I'm using action words. I'm using commitment words. Those are great opportunities for the provider. When we think about pre-contemplation, think about, you might see this as defensiveness, not asking for help. They don't really want to hear what your advice is about a certain thing. That would let you know that they're kind of in a pre-contemplation stage. And something I used to think about this is, these are the kind of kiddos or patients that present for kind of acute care. Something's wrong and they take care of it right then. They're not actively engaged in regular checkups or thinking about whatever challenge they might have with their hypertension and how best to take care of that. They're just really not in the space to think about their issues. Am I going too fast? Everybody okay? All right. So in this contemplation stage, think of those people on the fence, that there's an opportunity there to tip the balance. We've talked about that before in some of my MI presentations, that you can just kind of nudge a little bit and maybe push them into making the plan for change. Gently nudge, not push.
I like the reference of planting a seed, so you're giving them the inclination to think about it further.
Okay.
Was that a question from out there? Okay. Yes, plant the seed. Things for someone to think about. And then that also gives them the opportunity to think about, if this is really important and I want to do it, how might I do it? And so there's actually some time spent on thinking about what the plan would be. So what would we do if they're not interested in changing? Well, we raise doubts. We provide information and an open door. I'm concerned about, I would like to talk to you about, maybe next time we could talk about that thing. The ambivalence about changing is that tipping the balance when you ask those questions about, well, what's really good about what you're doing? What's not so great about what you're doing? And try to provide information, a feeling of try this and just push them over a little bit to think about making the change. And I've done talks about that before, and that information might still be on the website because there's some really pointed questions about tipping the balance that you can use. And then the committed to changing, you hear it in the I know, I can, I want to, I believe that. Those kind of commitment words let you know that they're ready to take that next step. And as soon as someone verbalizes their need, desire, ability, some of those change talk words, to make a change, we can predict their behavior. Okay, they're going to try it. Doesn't mean they won't relapse or not be successful along the way, but those kinds of words, that predictive language lets us know they're ready to try and make the change. It's important to talk about ambivalence before we move into the assessing readiness, because that we find lots and lots of places. So let's just, I can't really have a show of hands out there in the virtual world, but how many around the table here think about a health behavior change they'd like to make? Have thought about, simple
And actually,
one.
we can have them raise the hand, so they can. You on your webinar, you can give Kevin a hand on your screen, so we can count those.
There's a change you'd like to make. Walk your dog more, cook more dinner, spend more time with your kids. Are there, How many out there find it a little bit challenging to make that easy change? The ones that you feel like you have control. I could walk my dog more. It's not easy. And so if we have all these great brains around this table thinking that, yes, it's a challenge and I'm not always successful at it, we can imagine what it might feel like for a patient with just all kinds of issues going on, particularly when we think about pediatric obesity. Do you know what this telehealth program is for? There's a lot going on, and so it's not easy to make a change, even those ones that we think are simple. So when we think about ambivalence, recognize that resistance to change can often be ambivalence. It's not really that they don't want to change, it's that they're not sure how they might do it, and they're still on the fence and maybe need a little bit of a nudge. If you argue for one side, the ambivalent person's going to take up and defend the other. And we've done some funny metaphors about that, about getting on the bus. And if I'm arguing for this side and there's 2 seats on the bus and I've taken up the seat, there's no room for that person to move over there and make that change so they have to defend why they're doing what it is they're doing. And so there's no room then for negotiation. Try not to take up the good side, even though you know in your heart what the good side is. Let it come from your patient or client. Often, patients aren't even aware of the conflict in belief in their behaviors, and that's when you can use some of your tools like developing discrepancy. On the one hand, but you also say, I'm curious about why those 2 things don't match, and just kind of let it come. And then they recognize for themselves, wow, I am kind of ambivalent, and I'm talking out of both sides of my mouth, and how might I choose one way and just go down that road? Yes?
One of your favorite questions that I use all the time, because I can't remember that sentence that you just said, is I'm confused.
I'm confused. I say that a lot, particularly to my teenager. I'm confused. On the one hand, you said, you study for your test. On the other hand, you got a C. Tell me about how that worked. But that's kind of exploring both sides of the equation, right? Were you thinking of the 3 questions?
No, but I end up using that confused one a lot because it's easier to remember. And it also makes, it takes the pressure off me as being the expert. It's okay for me to be confused. Yes. So that power differential's gone because I don't know.
That's interesting you say that. Kirsten, because I think that it's very, very, and it's most beneficial, actually, for our patient or client to come up with their own answers. You know, and so by pointing out your confusion, they go through a little more of a process about thinking it through and answering why something might be that way, even though we don't ask why questions. Really. Only sometimes. Right, Dr. Dan?
Columbo made a career of it. It's kind of a dated comment.
I know who Columbo is.
Can you help me understand that?
Yeah, see? Help me understand.
It's too bad they can't see you, Dan, because that's really good.
This is our opportunity, too, to work with the discrepancies between their goals and values and their behavior. You know, my goal is to weigh 20 pounds less. However, I really haven't given up the big gulp every day after work. You know, those are the opportunities to work with ambivalence and work towards, you know, maybe setting some changes, some goal changes. How do we know when people are ready to change? What clues could we be looking for in our interactions with them that let us know this? Well, there's decreased resistance. Okay, they're more open to the ideas you have and maybe even more open to you giving direct advice. There's decreased questions about the problem. They're not as curious anymore about what it means to have hypertension or, you know, non-alcoholic fatty liver disease. They're understanding. There's some resolve and resolutions. I understand I'm 20 pounds overweight and I really need to work on that. That would also be a self-motivational statement. There's increased questions about change, like, well, how would I feel? What would I eat differently? There's imagining that person who's gone through the change and what it looks like on the other side, and then there's experimenting with new kinds of behaviors, and you'll hear these things in your interactions with your patients. So here at Envision, we use the ruler a lot. I would like to say this isn't the only way to assess readiness, but it's a pretty quick one that I think could be helpful to medical providers who don't quite have the time that behavioral health providers would have with a patient. So when we assess, we're in a curious state. We're trying to understand where a patient is on their readiness, perhaps, their importance, or their confidence. It's important, as the provider doing the assessing, that you're really genuinely interested in what they're saying and what their answers are. You know, they can tell when we're just going through the motions. And so if this doesn't fit your style and you're not comfortable with this, I recommend you don't do it. Quite frankly. Use your active listening skills, your critical thinking skills while you're asking these questions. Think of this as your goal is to learn exactly how this person feels about the topic. And remember that asking how ready are you could be a little confusing to people, because that hits on things like their desire, their ability, their belief in their capacity all at one time, and that could be a little confusing. And so I'm going to talk about another way you might ask readiness without using the word ready. A lot of times, it's very common, I've noticed in the medical field when we're assessing readiness, that's the only question used. How ready are you? And that's where the conversation goes. But it's very, very, very important that we talk about importance and confidence, because that's going to give us a much more rounded picture of where our patient's at and how much of that self-efficacy they believe, you know, they have to make these change. So, why assess importance and confidence? Well, there's a dual utility. It provides information about how patients view the importance of changing. It provides information about the extent to which they feel it's possible. And it can be used to help patients give voice to what they would need to do, to say out loud, perhaps what their barriers are, what will be expected of them, how it will impact their day-to-day, their fear about letting go of their cigarette smoking habit, or, you know, those things bring up fear in people. And this gives them an opportunity to express that to you. I'm just taking a little breath because I feel like I've been talking really fast. Okay, so let's talk about importance. Importance is determined by what value a person places on making a change. And that tells us a lot about where they're at. So on a scale of 0 to 10, how important is it to you to make this change? You can say 0's not at all, and that tells you something about where they're at. If they tell you a 1, you know, there's a little bit they're thinking about. If it's 0, that's nothing. This is not important to them whatsoever. Move on to the next topic is my advice.
May I make a comment?
Yes.
When you use this scale, it's best, like, if someone says a 5, it would be like, why a 5 rather than a 10? To go the other direction, why a 5 rather than a 0? So you're articulating their motivations rather than their resistance.
Yes, we were just going to talk about that. Backwards, forwards. No, I appreciate that. That's great. No, that's great. So it lets you know how they feel right now about whatever that behavior change, how important it is for them personally. But it also, as you just alluded to, it lets you know what would have to happen for them to do it. And then if you do this, it's called the backward question. Why are you a 5 and not a 3? Well, then you might find out, well, because I've realized over time that my smoking is affecting A, B, and C. So I'm not quite all the way ready to make that change, but I'm moving in that direction. You know, it's more important to me than it was last time I met with you. Ask a straight-on question. What makes you a 5? Wait for the answer. You know, it lets you know just where they're at and thinking about this goal. And then the forward, what would it take to move you from the 5 to the 7? And then that tells you some of their perceived barriers or some of the things that might be more important to them. Yes, quitting smoking is important to me, but really what I need to do is get my blood pressure under control. Or I need to add that extra day of walking. That's more important to me right now. That tells you something about where they're at. Confidence is their belief in their ability to make the change, their self-efficacy. Now again, we do the 0 to 10 so that we know, but it tells us how much they believe in their own ability and also what their perceived barriers are. If I'm low in confidence, what is it? I can't wake up early enough. I work 3 jobs and I don't have the time for that extra walk. I mean, it can be any number of things. Or I just don't have a lot of self-discipline and I'm not confident I could do this every week. Well, there's an opportunity for you to explore together how you might support them in their self-efficacy. Another way to ask about confidence that I think you might get a little more information than just the readiness scale is if I wrote them down. If you decided right now to make this change, how confident are you that you would succeed? Well, mildly confident or super confident, you know, depending on what their answer is. But explore with those open-ended questions, you know. We've talked about open-ended questions. I'm going to assume a certain level of knowledge about open-ended questions around the table right now. But that's how you would get further into how confident they believe. You could also ask, what would make you more confident? Some more time, some more reading materials. Would you like to come back and talk with me? You know, what are the things I could do to bolster the confidence? Is there any way I can help you? Is there anything I can do to support you in this? And then you can ask those forward, straight on, and backward questions. If you're a 7, why not a 9? You know, those kind of things to just explore, further. So then what's next? If importance is low, focus here. I would argue, and like I said, I'm not an expert, but my personal opinion, I would argue that importance is really more important than confidence. Because if it's not important to them, it really doesn't matter how confident they are. They're not going to work on it. They're not going to make a change. And that's an opportunity to for you to give a little more information about why you, as their healthcare provider, feel this is important. And it is very okay for you to say that as their healthcare provider. Mm-hmm. If their confidence is low, you lend support, you ask how to help. And the main thing here is that if both are low, maybe now not the time. And if you can accept that, not try to push it, you've left the door open and you've left an opportunity for that patient to come back and talk more about it with you. And it's okay to say, I'd like to invite you back in a month to talk about this again. Who knows what'll shift in a month? But I know that there's often a need particularly when you've got a child that's overweight or obese and there's lots of comorbidities, that you need to say the thing you need to say as their healthcare provider. Like, I am scared for your blood pressure or your... It's okay to say that and just leave it at that. Not ask them to do anything about it, but to say out loud what your concerns are. I have some references also. And then there's going to be more on the website because I found other things as I was going along about importance and confidence that I thought might add to what I spoke to today. And I know I kind of went fast and it's hard to do in a webinar, but I'm here for questions and thank you all. Does anybody have the cricket button?
Do you want to check and see if anybody else has signed on?
Okay. So,
Can I
go ahead.
I just want to do roll call. I came in after about 10 minutes.
Okay. And your name?
Carla Blodell.
Hi, thank you.
Thanks.
Anybody else want to check in?
Yes. My name is Janet Lucero, and I checked in a few minutes late. I'm a school nurse in Socorro. Thank you.
Yes, I see your name. Thank you.
I also need to sign in Dr. Leslie Ward and Dr. Cecilia Concepcion at Journal Center Pediatrics.
Great, thank you. Thank you for joining.
And I'm Ivy Hampton.
Ivy, we have your name too. Thank you. Anyone else? Okay. Well, so does anyone have any questions, thoughts about assessing readiness or working with ambivalence or the stress about not being able to just say the thing to your patient that's bothering you that you want them to do?
I want to state that I think most patients know where they're going wrong or what they need to do. I mean, nutrition, as from my standpoint, isn't that complicated. Most people know what they should be doing. It's just, how do I keep them going on that track? How do I keep them verbalizing their barriers and their reasons for change? So usually they do a majority of the talking.
Mm-hmm. Well, so there's a beautiful article written about the ratio of talking when you're in an MI interaction, and it's about 70-30. 70% is the patients and 30% is the provider. And anything... you might even want to go lower, that 80% is the patient and 20% is the provider. That kind of lets you know that you're in an MI style, so that those opportunities for them to just verbalize and express the barriers, and you can grab hold of them and work with them.
I just wanted to make a comment about that. I'm not sure that nutrition is as easy as we think for people who haven't ever had an opportunity to be educated about that. I'm often surprised, if you think of our advertisement with, Coca-Cola at the Super Bowl and all these things, and, McDonald's, Wendy's, whatever, I actually think that a lot of my patients, it's not that they're being resistant to change, they just don't understand that a Coca-Cola is not right for a kid. So I would say, before you assume they're being resistant, see what they really do understand, because it might just be that they haven't been educated about that nutrition. We see it every day, but they might not have an opportunity to talk or think about nutrition.
Right. Thank you. Yes.
Beth, this is Kirsten. I would agree with you. I think that's unfortunately one of the problems that we have, is that that underlying sort of institutional knowledge or population knowledge about how to care for ourselves nutritionally is gone, and it's been over the last generation and a half, and so it's trying to figure out how to get that sort of back into the mainstream, because again, I don't think people understand that taking your kids to the McDonald's and offering them juice in a cup or soda in a cup is not considered normal. I just took a couple kids to the fair last week, and that's always the boldest example of choices that are being made.
One day we're going to make bad ones all day.
Oh, yeah. And so it was interesting with the two kids that I was with, one being mine and one being Carole's. having to negotiate with them what bad choices we were going to make in the 5 hours we were there. In other words, we weren't going to make one every hour. We planned out our route, but again, that created again an opportunity for hanging out in the agricultural building with the fruits and vegetables and trying the New Mexico foods and all of that, and then going to the dairy barn for the homemade cotton candy. But I think that's actually a real issue, and I think I'm not quite sure what the solution to that is, because I don't think we can assume that people know what they're supposed to do.
We're confused.
Yes.
Look at the breakfast thing that just came out. How important is breakfast really, right? Forever and a day we've been hearing this, the most important meal of the day, and it's going to help with obesity. And then that, just 2 weeks ago in the New York Times, well, maybe it's not that important. And so,
well, I don't know where that comes from, because there's years and years of research for that. But I think that the thing that's interesting is in that comment is that I wrote a blog post for the HSC website. They have a place for families to go, and so the gal that runs that has me doing a nutrition post for her every month. And you have 500 words, so you can't say a lot, But the thing that I said is eat something. Something is better than nothing. And something could be a peanut butter sandwich. It could be last night's leftover soup. It could be a granola bar. It could be, a glass of milk. And I'm trying to think, we were having a discussion, I think it was COMM-TC 2 weeks ago, about the breakfast burrito. Did that come up? Someone was talking about the kid who was going to Allsup's for the breakfast burrito. And so there were, the provider group was sort of up in arms about the Allsup's burrito. And I was like, I'm just happy they're eating breakfast. So the issue is the child's eating. Now how do we manage this child's insulin needs around that particular food choice? Because in the short term, the child at least got some calories to turn their brain on and their metabolism on before they headed to school. So I think there's still a space for us to discuss that, about the importance. I think the issue is you can't not eat for 12 hours and expect your body to work.
Right.
However, you do have a sort of an array of things that will turn your metabolism and your brain on. And I think that's where we get hung up, which is, again, talking with families about where they are. What do they see as the perfect meal? And this is sort of the thing, getting into this, how we can use motivational interviewing to deal with our issues of cultural competency.
Yes.
Or sensitivity, because it's
Yes.
not really competency, it's really sensitivity.
Yes.
And so Carole and I have had this discussion about, you don't really need to be culturally competent if you leave people a space to tell you what it is that they need or what's important. And then you are being sensitive to the fact that their needs might be different. So if someone tells you that what they're eating in the morning is, what you heard was they're nourishing themselves in the morning. So, and it might be that there are some places for change there, because maybe that thing doesn't quite fit with their insulin regime, or their medications for their lipids, or their medications for their treatment of their hypertension, or whatever it is. But at least you have a place that you can start the conversation. There are a lot of folks that have worked on POW that are out in the audience. POW meaning our Pediatric Overweight Initiative, that I noticed who signed on, and I wondered if anyone had any comments, having had an opportunity in years past, some of those providers, for some more formal training where they've had 2 or 3 hour sessions and a few of these short sessions, if what that looks like for them.
Well, I was not to call Dr. Kasimsab out, but she was an early adopter of the motivational interviewing, and has, been to, I think, more than one multi-hour training, and I think she works at using this in a lot of her patient interactions. And if you're still on the line and would like to speak to this, Dr. Kasimsab, we would appreciate it.
Yes, Carole, I'm still here, and yes, I am. I've been really trying, and that's why every time you talk, I sign on, because this takes so much practice to do motivational interview, to be able to be comfortable at it as well. Like you said, if you're not comfortable, the patient sense that. So it's very true. I have found it to be a great tool in motivating the patient to make changes, to move the scale a little bit, and it can be any range from pediatric overweight to even asthma, compliance with medication. I mean, it's just a really great tool. I find that probably what I have found sometimes with patients who come in, and these are usually the middle schooler, kind of 11, 12, where, you know, they're not really old enough to really take care of their health or don't have that understanding of the concept to take care of their health, but they're not young to where the parents can control everything they eat. And they come in with overweight, and those are the toughest patients I find because the parents are really trying to get these kids in an authoritative way, like, you know, you can't have a soda, you can't eat chips, you can't do this. But the kid doesn't really, you know, they're just like, no, I'm going to do this. So it gets into a battle between the parents and the kid, and I find that to be a really hard scenario to try to get motivational interview going, you know. So it's almost like the parent is badgering the child, and the child is sitting there, you know, fighting back. And I don't know, how do you approach that? That was going to be one of my questions.
Well, and so that's a tricky one. That's when you need the UN School on Mediation and Negotiation skills. That can be really tricky to figure out what mom's needs are, to figure out what the child's needs are, and to make, you know, as 11 or 12, they're trying to decide for themselves what things they have control over. And so I wonder, and Dan, I'd like you to chime in after me if you have some thoughts on this, but I wonder about having time separately with mom and the child and finding out what could be the happy median. Like what would she let him, what's okay with her for him to cheat? Soda, you know, that if he really wants a soda, is she willing to give him that? If he's willing to give up chips as a snack after school. I mean, there's some negotiation in that. So any of the providers around the table who regularly see families, I'd like to hear what your ideas are on this, because I haven't been in the clinic for, 5 years now. Yes.
Well, Carole, I'll take your invitation to chime in.
Thank you.
With the following, and it's not very elaborate, because I'm not sure that I would not tread into a very large request initially. In other words, I don't think that I would be asking for a very extensive negotiation.
Okay.
While at the same time respecting the developmental need of the child, which I agree with you is very important, and I'm glad you brought that up. And 11 or 12-year-old pre-adolescent, they're really in that bridge between being in those latency years and being an adolescent, and it becomes important to allow some choices. And I think it's very appropriate for the parent to still keep it limited and concrete, because they're really still cognitively starting to reach their full competency as far as their more concrete operations, and they're really not moving on to their formal operations as far as the Piagetian scheme goes.
Okay.
So I think that if the parent would say, you need to be having 5 fruits and vegetables a day, for example, and you have a choice about how you're going to do that. How many of them are you going to have at breakfast? How many are you going to have at lunch? How many are you going to have at dinner? How many are you going to have at snack? So there are all kinds of combinations. There could be 1 in 5 eating opportunities a day, 3 meals and 2 snacks. Or it could be 2 at a meal, 2 at a meal, 1 at a meal. And the child can make that choice.
So that's where he has some power, he or she has some power to decide when.
Right.
So what about on the tricky stuff, Dan, with like they're eating really the worst food choices? You know, that after school
there
snack,
are going to be opportunities down the road to get to that.
Okay.
I would start with the desire, what we see as the healthy foods, because they're desirable for us as parents.
Right. Right.
Okay, and I think that we need to make it a program of attraction.
Right.
And I think by trying to take something away at the same time, it really starts to confuse, to complicate it.
Right. Thank you. That's a good answer.
And then later on that can be negotiated further. Or maybe it gives an opportunity, in other words, for the child to become zealous about it. And maybe they'll decide that they like the fruits and vegetables, they like to cut up carrot sticks. You know, there can be opportunities for the child to ask for celery and the parent to talk about, okay, well, I'll have cut up celery and carrot sticks in the refrigerator for you after school. And that can be a negotiation without thinking about negotiating.
Okay, that's good. Yes,
so that can be something to chew on anyhow.
Okay, Dan. So I was also thinking about something you said earlier about not negotiating. And I just have to have this plug out here again, that the parents are the keepers of the safe environment. And so it's up to the parents, if you have that separate discussion for them, that maybe part of that discussion would be that parent says, you know, I just feel like I'm always fighting about food and it's always around the chips. And asking a question, what would it look like if there weren't any chips in the house to fight about?
Right.
Because that may not be something that they've considered. And then the negotiation is gone from the standpoint of the day-to-day kinds of things. So what you're doing is modeling, this is the way we eat. Now, it doesn't mean that when you go to the fair that you aren't going to say, they're going to say, hey, you know, we're surrounded by corn dogs and cotton candy. Can I try one of these when we're at the fair? And you say, yeah, it's fair day. We're going to do some crazy stuff while we're here. However, not having that at home. So just reminding us in our clinical sort of interactions with parents that they still are the parents, and it's okay sometimes to be unpopular by making a choice to give the child an environment where any choice is relatively safe, whether it's the carrot sticks, the celery sticks, the cucumbers, the apples, the bananas, you know. So there's a lot of choice, and none of the choices are bad.
So environment control.
Environment control.
And positive reinforcement.
That helps too.
Yes. Does that help, Dr. Kasimsak?
Yes, thank you.
Are there any other questions? Any good plans for the weekend? Yay for the weekend!
If there aren't any other questions about the actual clinical application, I'd like to ask a more theoretical question.
Yes.
And it's not because it's a focus of the presentation. It's because time and again it's been mentioned that the stages of change are really not central to MI.
Right.
And at the same time, I think every presentation, at least the ones I've gotten to see, have had stages of change as part of the MI presentation.
Even Dr. Bolton-Etzel, Carrie would use that stuff.
That's right. And others, and at national and regional conferences. And so I'm curious about that relationship. Is it that the stages of change happen to be a great example? Or are there some components of the MI challenge that are represented in, which is really saying the same thing?
Well, I was going to say, I think the answer is yes to both of those, in the sense that when you look at that spectrum of the stages of change, you think about where opportunities are to talk about motivation and where we might find a way to motivate people. Like, what are the spots along that continuum of the stages of change? And I think it gives a nice way to organize MI, because sometimes I find the stuff around motivational interviewing to be kind of, what's the word, esoteric or nebulous, or, you know, not as concrete as like CBT or something like that. So I wonder if it's just a way to organize thoughts along the spectrum of motivation about where you might intersect effectively with someone. Does that make sense?
It might also be that in a lot of education programs for healthcare providers and educators, they present stages of change. That's like part of sort of a core education. So it gives everyone a place, a common vocabulary. So you talked about the trees and the leaves. Everybody
common
has that.
vocabulary.
Everyone has that tree. So when you start adding on those leaves around motivational interviewing and strategies, you're putting that onto a framework that somebody already has existing.
You know what I don't know the answer to is what came first. You know Bill Miller's work on the theory of motivation and motivational interviewing, or the trans-theoretical model of change? Do you know, Dan? I'm wondering about that. But it seems like the stages of change have been around a really long time.
I suspect that's the case.
I think they were, you know, and so maybe that was just a way to look at when we were looking at the theory of motivational interviewing, the theory of motivation, there were places that it made sense to focus the work.
So. Area of further inquiry.
Your weekend reading.
Not this week. Okay. There's one more little quick thing I want to show you. Some of you that have been around Envision for a long time might remember Dr. Carrie Bolton-Etzel, and she did a lot of our work around MI, and I dug this up, found it, I'm not even sure where, on our mysterious, what we call the O drive server, where people work on things and then they kind of disappear. But I found this schematic for screening for readiness. And we'll put this on the website if you'd like to have it. It's probably already up there. Thank you very much, Kevin. Now, the one thing I would point out about this is that it doesn't have importance or confidence. So you might want to add it if you were going to just follow this.
If it's important.
If it's important, yes. Thank you, Dan. But what I really like that she did is, what are the 2 best reasons? Because if we have those in our notes, if we have them filed away in our memories about our interactions with this particular patient, we might use it to come back to them to remind them about, why was this important to me?
I think what Dr. Bolton-Etzel was doing there, Carole, with those 2 questions was essentially allowing an expression of the patient or client's subjective importance for making those changes. Yes. What are the 2 best reasons? I think that's basically talking about the importance. So this is on our website, and feel free to download it and play around with it a little. And I think it's a neat, how she said, please come back and see me if you change your mind. Carrie was always okay with people not being ready to make any kind of change. Now, I'm just, okay, I'm here and my door's open.
I do wonder, though, to what extent a clinician can always say that.
I know.
And say it with appropriately in response to what you're seeing a child for. Because if he's 6 and his blood pressure is 130 over 90, we don't really have the option to say that, really.
I know. And so
I think it's a good point, and one that you probably shouldn't lose track of, but it's a little murkier for me.
Well, Jane, that's why I talk about the spirit of MI. That there are times where you just have to say the thing that you're afraid of, and that you need them to work on and make a change, and is there anything I can do to help you with this right now? Then there's no guarantees if it's not important to them, but I absolutely believe there are appropriate times for clinicians to just drill into that thing. And let's not mess around with where someone's at on their readiness, because we're afraid for them.
Yeah, you don't get to be ready today. This is just what we have to do.
Yeah, and that's fair.
I'd like to comment on that again from the developmental standpoint, because in the example that Jane mentioned, it happens to be that the child is 6, and it's a developmentally
which was sort of arbitrary, just to,
of course.
To give
the parents might have
a background
about how ready they are.
Right, but then it's very appropriate that the parent is deciding how important it is.
Right.
Mm-hmm.
And it actually can be appropriate when it's going to be life-threatening for other outside individuals making that determination. And yet, as the child is getting older, they can show the ability to make choices and be given options. And it may be that the diet needs to change, okay, or the lifestyle, including exercise, needs to change, but then the greater number of options are presented through which to make those changes. that are identified as necessary.
Yes. And I think I would just like to say, as MI trainer, behavioral health provider, I'm not even sure sometimes what my role is here at Envision, but MI is just another tool to have in your toolbox. It is not the end-all, be-all, and it won't guarantee you that you make a deal with somebody and they follow through and the change starts happening. I'm just saying that out loud. There's just something else to have in your back pocket when you run up against some walls with older patients in particular of making change. So we don't have to all hang our hats on MI as the only way to get through a health behavior challenge. So. Well, so thank you very much. I'm guessing we have no more questions or comments. There are, right now this little schematic is up on our website, but I will be putting a couple of more tools to use when you're thinking about change and assessing readiness, like a decisional matrix, and then some articles I found that were really, really interesting, and I just didn't get it all together before this presentation, so.
Is there a way to be certified in MI?
Yes.
Okay, we put that up too.
Well, I guess I would
put
have
the
to
link.
The link to the MENT.
Okay.
Motivational Interviewing Network of Trainers. That's probably would be what you would consider the gold standard or the premier of MI folks out there.
Okay.
So, yes, I can put that information out. Practice, practice, practice. Okay, well, thank you all very much. Thanks for coming to COMM-TC. Do we do the final roll call, Kevin, or we just close out? I'm not sure.
We sure can. If anybody has not announced their names at this point, this is your chance to do so. Sounds like we're in good shape.
Okay, well, have a great weekend. Last weekend of the fair. Go eat.
Fair enough.
Thank you.
See you in 2 weeks.
But I said Jane's going to be here, Dan's going to be here, Beth will be here. I mean, it's not like we don't have a bunch of providers.
You're talking about our director?
Yes, our director was concerned that I was not an endocrinologist. I said, yeah, I'm aware of that one.
Got the memo.
By the way, will our director be back on Monday?
Yes.
Okay. By the way, I noticed on your slide that Carrie is listed at UNM Pediatrics, and
still?
She's formerly UNM Pediatrics.
Right, she's now in New Zealand. I'll fix that. Thank you.
You could put Carrie Bolton-Etzel down under. Or maybe...
No, that's Australia, isn't it?
That's Australia, isn't it?
Yeah.
Yes.
What would be the counterpart?
Down under.
Yeah, but they're relative neighbors.
Further down under?
Thank you, Dan.
Down somewhere.
I will fix that.
It's like a 3.5-hour flight, but there's nothing else near them. So.
That's a lot better than the 14-hour flight.
From here to there?
Australia.
Yeah, you don't just pop over there to say hello to.
As close as they